It's my great pleasure to introduce this afternoon Dr. Nikolai Podoltsev, and many of you know him, but we're very fortunate to have him here with us today. Dr. Podoltsev is an associate professor in our Department of Medicine in the section of Medical Oncology and Hematology. He did his MD and PhD training, got his MD with honors and his PhD subsequently at the St. Petersburg State Pavlov Medical University in St. Petersburg, Russia. He also completed his internal medicine residency there and a postgraduate fellowship in hematology, which he completed in 1997. And thereafter, he came to the United States and completed further internal medicine residency and internship training at St. Raphael's campus of Yale New Haven Health, and served for a year as the chief medical resident there. He also completed a hematology oncology fellowship at Yale School of Medicine in 2010 and has been on our faculty now for many years. Over the years, Dr. Podoltsev has held several leadership positions at our institution, including serving as the medical director of the Department of Medicine at the Hospital of St. Raphael's through 2007, as the director of the Yale-affiliated hospital program lecture series for hematology, director of the Hematology Tumor Board, and also for 5 years served as the firm chief for education for the inpatient hematology unit, the Duffy firm. He currently is the Associate Director of Medical Oncology and Hematology Fellowship Program, has done so since 2010, and is currently the Clinical Director of the Malignant Hematology Division and Chair of the Hematology Oncology Fellowship Clinical Competency Committees. Over his career, Dr. Podoltsev has received numerous regional, national, and international honors and awards, including several for outstanding academic performance, outstanding residency awards, and teaching awards, including he's the three-time, not once, but three-time recipient of the David S. Fisher Annual Award for Outstanding Teaching and Mentoring in Hematology at the Yale Cancer Center. And most recently, he was the recipient of the Yale Cancer Center Award for Clinical Excellence. His clinical practice focuses on acute leukemias, myeloid neoplasms, aplastic anemia, and other bone marrow failure syndromes, systemic mastocytosis, and hypereosinophilic syndromes. He has participated for many years and still actively participates in clinical research, including numerous clinical trials and outcome studies on novel agents to treat myelofibrosis, polycythemia vera, and various hematologic malignancies. He has active grant funding and also has served and chairs peer review and data monitoring committees for several clinical trials. He's a highly sought-after speaker, faculty speaker, both nationally and internationally, in regard to hematologic malignancies and myelofibrosis. He serves as a manuscript reviewer for many notable journals and is a member of several professional organizations and is extensively involved in both university and hospital committees here at Yale. He represents the Yale Cancer Center and Smilow Cancer Hospital on the NCCN guidelines panels for various hematologic malignancies as well. He has also published widely in his field of expertise, having more than 150 publications, including original research, reviews, clinical practice guidelines, and case reports in such distinguished journals as Nature Genetics, American Journal of Clinical Pathology, the British Journal of Hematology, Cancer, Journal of Clinical Oncology, Blood, Nature Communications, Lancet Hematology, the New England Journal of Medicine, and many others. So it is indeed a pleasure and an honor to welcome Dr. Podoltsev to give his Pulmonary Grand Rounds lecture today on the approach to hypereosinophilia and hypereosinophilic syndromes, a very complex and challenging topic. So thanks, Nikolai, for being here with us.
Dr. Rochester, thank you for this amazing presentation of myself. So I hope that my lecture will stand behind it and I'll be able to prove that I can teach. So the topic today, and I truly appreciate the invitation, is approach to hypereosinophilia and hypereosinophilic syndrome. And this is a multidisciplinary subject to which we approach as a group. And that certainly includes hematology, but also pulmonary and critical care physicians. And this is the disclosures I have. Nothing is having direct relationship to what I'm going to talk about today. Just a reminder, the CME code you have to text to the CME number for today's presentation is 53901. So I would like to start from a patient who's currently actually admitted to St. Raphael's campus, and I saw her for a couple of weeks ago. So she presented originally, she's 33 years old woman with hypereosinophilic syndrome. Absolute eosinophil count is 20, and she presented with fever and right upper quadrant pain radiating to back with labs and imaging concerning for acute cholangitis and colitis. So she had urgent ERCP, which showed moderate severe distal common bile duct stenosis concerning for primarily sclerosing cholangitis, and underwent biliary sphincterotomy and plastic CBD stent placement. So eventually biliary brush path came back with abundant eosinophils. She was admitted after the procedure to medical intensive care unit due to hypothermia and hypotension with concerns for sepsis versus cardiogenic hypotension in the setting of cholangitis and post-ERCP pancreatitis. So workup of hypoxic respiratory failure included transthoracic echocardiogram, which showed severe mitral valve insufficiency and left ventricular clot. She was found to have a significantly elevated troponin as well as pro-BNP, and had right heart catheterization with endomyocardial biopsy, which was complicated by hemipericardium requiring drainage. The pathology showed myocardium with focal myocyte necrosis. Eosinophils were not described. Pericardium with no significant abnormality. I don't know if it was the purpose of the procedure to biopsy pericardium, so I think it was endomyocardial biopsy, but as the result, there was a complication with which she had to deal with. So she had two procedures, unfortunately, two complications, pancreatitis and hemipericardium. So the question is, what workup for hypereosinophilic syndrome does she need to have, and how hypereosinophilic syndrome should be managed? We will review some slides, and then eventually we'll get back to this patient, and I'll show you what workup she had, what type of diagnostic categories we are considering for her, and how she's being managed. So first of all, I'm a hematologist, so the reason why I'm engaged with this subject is because eosinophils are blood cells, which we see on peripheral blood smear, and they're kind of remarkable because they have this eosinophilic granules. You can easily recognize them. They are terminally differentiated myeloid cells with bilobate nucleus normally, and granules stain red with acidic dye, eosin, and that's why they are called eosinophils. So they're inflammatory cells, and they're protecting against Helminth infection and participate in allergic inflammation. The main cytokine involved in their survival, differentiation, activation, interleukin-5, which is produced by many different cells, including eosinophils themselves. But also there are some other cytokines which may be involved, including interleukin-3, GM-CSF. The other group of cytokines which may be important in the damage which eosinophil causes in the tissues are interleukin-4, interleukin-13, and TNF-alpha. Eotaxins produced by tissue cells in response to inflammation signals to recruit eosinophils to tissue where they can lead to organ damage through release of mediators stored in the cytoplasmic granules. Normal eosinophil count is usually less than 0.5. Now we categorize eosinophilia as mild, 0.5 to 1.5, moderate, 1.5 to 5, and severe when absolute eosinophil count is more than 5. So this slide contains definition of hypereosinophilia and hypereosinophilic syndrome by International Cooperative Working Group on Eosinophilic Disorders. And hypereosinophilia is defined as absolute eosinophil count 1.5 or higher, which is persistent, and the interval is usually 2 weeks. If within 2 weeks you still have elevated eosinophils, that's hypereosinophilia. Tissue hypereosinophilia includes one or more of the following. If we biopsy the marrow, more than 20% of cells are eosinophils, that's hypereosinophilia. Pathologists may call it without specific number, just looking at it, saying that there are too many eosinophils, more than expected. And finally, there may be deposition of granules from eosinophils, the proteins, and they may be found without presence of the cells, which disintegrated. So tissue hypereosinophilia presumes that there is increased eosinophils in the tissues, but also can be circulating. Hypereosinophilic syndrome is presence of hypereosinophilia and organ damage. So specifically, organ damage attributed to high eosinophils, and the other reasons for organ damage should have been excluded. Finally, there is this infrequent situation when you have tissue-restricted hypereosinophilic syndrome, when there is no circulating increase of circulating eosinophils, but there is presence of eosinophils in a specific organ, causing its dysfunctional damage. For example, eosinophilic esophagitis. So these were definitions, and now classification of hypereosinophilia. So it's too challenging to navigate this subject in part because there are different labels affixed to different patients, and having understanding of classification, speaking the same language is one of the first steps to kind of finding the consensus about diagnosis and management. So infrequently, we see hereditary or familial hypereosinophilia. Actually, I never saw one, but there's clustering of these patients with high eosinophil count in families, and they usually don't have any manifestations of that. So family history may be important in figuring out who has hereditary eosinophilia. So there is hereditary eosinophilia of unknown significance, sorry, not hereditary, but hypereosinophilia with unknown significance. And these are patients who don't have hereditary problem, but they have high eosinophils, and they do not really have any underlying condition we can see to cause hypereosinophilia, and no signs or symptoms of hypereosinophilic syndrome, damage to the tissues. There is secondary reactive hypereosinophilia, where eosinophils appear due to known secondary cause. This is not a clonal eosinophilia where eosinophils are made in the bone marrow by myeloid malignancy. This eosinophilia is triggered by one of the known causes. And there is no sign of or symptoms of hypereosinophilic syndrome when it is just eosinophilia. Finally, clonal neoplastic hypereosinophilia is the one which I deal with, and this is the one which is related to myeloid malignancies, where eosinophils are produced by a clone. And again, this is just hypereosinophilia, so not a syndrome. In that case, there is no damage to the tissues. So the difference between hypereosinophilia and hypereosinophilic syndrome is obviously presence of that damage. So clinical manifestations of hypereosinophilic syndrome basically can affect any organ, and that's one of the problems. That's why it is a multidisciplinary approach may be required to manage these patients. So the study, which was published a while ago, looked at frequency of different manifestations, and it looks like dermatologic manifestations are present in more than 2/3 of patients. The second most common involvement is the lung, so pulmonary, and that's why I'm talking to you. The GI manifestations in 1/3 of patients, and then cardiac manifestations are less frequent. So you have to remember the patient I started from, she has myocarditis with necrosis of the cardiac muscle, and also it looks like she does have endocardial damage because she has a clot in the left ventricle and significant mitral regurgitation. So the Loeffler endomyocarditis is kind of the next phase, and usually when you hear Loeffler, it means that the patient also developed restrictive cardiomyopathy, which this condition she has may progress to if we do not manage it right. So the workup of patients who present with hypereosinophilia involves a couple of steps. I'll try to make it as straightforward as possible, but it is complicated. So the first step is to exclude secondary causes. And the list of secondary causes is pretty long, right? So we have neoplasms here, and that includes solid tumors like lung cancer, as well as hematological malignancies, Hodgkin and non-Hodgkin lymphomas, especially T-cell lymphomas, which commonly are associated with eosinophilia. So adrenal insufficiency, allergies, and here we have asthma, allergic rhinitis, ABPA, atopic dermatitis, medical medications we use, which may cause eosinophilia, not only including DRESS syndrome, so it's truly hypereosinophilic syndrome due to the medication. And connective tissue diseases, a number of them here, I would highlight eosinophilic granulomatosis with polyangiitis, but also inflammatory bowel disease. Our patient actually has the picture on the RCP, which is consistent with primary sclerosing cholangitis, which I didn't highlight, is that the CAT scan, which she had done initially, also showed colitis. So it is possible that she has inflammatory bowel disease, and which is complicated by primary sclerosing cholangitis or associated disease. And, so that's why she has hypereosinophilia. So parasites, certainly she is actually from India, and there is concern that she was exposed to strongyloides infection, and that can certainly cause eosinophilia, and this workup should be included in her specific case as well as in the cases of a lot of other patients. And there are some others, immune deficiency, and so we have Gleich syndrome, which is intermittent, it's periodic angioedema and hypereosinophilia, so it can be seen in many different cases. Since residency, I remember this mnemonic, which helps me to keep the differential together, NAACP, so N for neoplasms, A for Addison's, another A for allergy, maybe 3 A's, because asthma is there too, connective tissue diseases and parasites. So that doesn't really encompass everything, but it's a good start when you approach patient with eosinophilia. So as an example of secondary eosinophilia, I would like to bring this patient whom I met on hematology consultation service. This 86-year-old woman presented with shortness of breath, and she has known asbestos exposure. CAT scan showed findings suspicious for mesothelioma. So as you can see, she has a left pleural effusion and circumferential thickening of pleura and mediastinal adenopathy. So the reason why hematology consult was called is because she has white cell count of 53, and more than 50% of those white cells are eosinophils. So absolute eosinophil count is actually 30,000. So we looked at the smear and we saw eosinophils. Remember, I told you they're usually bilobed, and so bilobed is here, right? So, but this is 3, right? This is a circle. So there's certainly a dysplasia. So it's not specific, but so it is a finding which we recorded. And then we proceeded with bone marrow evaluation. As a hematologist, I cannot not present bone marrow biopsy for pulmonologists. But I think what you can appreciate here without looking into details is presence of a lot of pink material on the biopsy. So those pink eosinophil granules highlight the eosinophils in the bone marrow, and their count here is 38%. Certainly more than 20, which defines tissue hypereosinophilia on the bone marrow biopsy. So she did have a pleural biopsy as well and was diagnosed with mesothelioma. So, and eventually she elected not to be treated and passed away within 90 days of this presentation. So she was 86 years old. So what I want you to remember here is that sometimes CAT scan of the chest, abdomen, and pelvis is helpful to look for possible etiologies of eosinophilia, especially if patients have systemic symptoms like weight loss, for example, because secondary causes include neoplasia, include solid tumors, as well as lymphomas. So the other type of secondary hypereosinophilia I would like to highlight is mysterious lymphocyte variant of hypereosinophilia. So the idea behind secondary eosinophilias is that the cells of whatever disease you're dealing with are producing interleukin-5, and interleukin-5 stimulates production of eosinophils, leading to high eosinophil count. And, so the high eosinophil count, no matter what it is coming from, primary or secondary, can cause damage and hypereosinophilic syndrome. Sometimes it does, sometimes it doesn't. So, but in this particular case, we know that there is abnormal T cell population somewhere in the patient making interleukin-5. And it looks like if we take all of the patients with hypereosinophilic syndrome, about a quarter of them may have this particular condition. So there is no consensus how you diagnose this condition, but there are certain findings which are consistent with it. That includes clinical manifestations. Most common clinical manifestation will be involvement of the skin. Pulmonary, GI are less common, and cardiac and neurologic are uncommon. There may be mild lymphadenopathy on splenomegaly, and T-cell lymphoma has to be ruled out. So biopsies are done not only of the bone marrow for these patients, but also lymph nodes if they are present. And lymphocytic variant of hypereosinophilia is not a malignancy, so perhaps it can be a precursor. The cells are clonal, and some of these patients may evolve into T-cell lymphomas. This rate is thought to be around 20% in 10 years. So this is kind of one of the secondary hypereosinophilic syndromes which I do follow in clinic. I try to stay away from secondary hypereosinophilic syndrome, like in case of asthma or some connective tissue diseases, which other specialists can manage better than I do. But this one, because of this hematological malignancy potential, I feel I'm the appropriate person to deal with. So the laboratory findings, also something I can interpret easily because I'm used to look at the flow cytometry. We do clonality testing with V-beta clonal analysis and T-cell receptor gene arrangements. One is flow, another one is a PCR test. Interestingly enough, these are the patients with the highest IgE levels I ever saw. I saw a patient with IgE level of 30,000. Obviously IgE elevation is not a very specific finding. You can see it in allergic diseases and in asthma, but these high levels are remarkable, and it is not always present. What it is due to is that, the abnormal T cell makes not only interleukin-5, but also makes interleukin-4 and 13, leading to B cell class switching and increased Ig production by non-involved B cells. And that is kind of one of the features I'm looking at when I'm trying to diagnose someone with lymphocyte variant of hypereosinophilia. So no consensus, but presence of clonality by T cell flow cytometry, the atypical phenotype of T cells, presence of clonality by V-beta analysis or T cell receptor gene arrangements, high Ig level, all to me are part of this diagnosis, as well as you have to rule out other things which are more obvious. So after we're done with step one, which by the way also includes other tests like strongyloides antibody, HIV testing, rheumatological testing, including NA and ANCA, and for some patients, not for everyone, CT abdomen, chest abdomen, pelvis, obviously stool form and parasites, and testing for lymphocyte variant of hypereosinophilia, we arrive to step two. This is, again, something I'm very much used to, and it may be more challenging for other subspecialists to deal with. So we evaluate for primary or clonal bone marrow disorder. And obviously here we will do bone marrow biopsy eventually, but there are some things we can do from blood as well. So I usually check for eosinophils dysplasia, and I just showed you that dysplasia is not really fully consistent with primary clonal disorder and can be seen in other situations, like in the patient I showed you with mesothelioma. The increased B12 level and tryptase are findings which are consistent with myeloid variant of hypereosinophilic syndrome. Again, not diagnostic because this is non-specific, but the easy test to do. Bone marrow biopsy with cytogenetic and molecular testing will help us to see if there is myeloid malignancy. And then FISH, which can be done from blood and, is basically turnaround time, maybe 1 to 2 days, is a very helpful panel looking for tyrosine kinase gene rearrangements, which may be driving primary eosinophilia. So we're also doing hematologic gene fusion panel for the same reason, to capture some of those rearrangements which may not be obvious by FISH. So this is my approach to clinical type of hypereosinophilic syndrome. So we have secondary or reactive on the left, and on the right are the ones I'm dealing with. I explain why I will go for lymphocyte variant hypereosinophilia. And then, so I'm certainly interested in looking at primary hypereosinophilia, so-called myeloproliferative variant of hypereosinophilic syndrome of MHES. And here I have idiopathic hypereosinophilia with myeloid features, where I cannot establish WHO-defined diagnosis, but nevertheless, there is a strong feeling that this is a myeloid disorder which is involved with elevated eosinophil count. There are a number of WHO-defined neoplasms which may be associated with primary eosinophilia. And finally, if I ruled all of it out, reactive lymphocytic variant primary hypereosinophilia, we arrive to idiopathic hypereosinophilic syndrome, where we have elevated eosinophil count and organ damage. So in fact, I'm dealing with lymphocytic variant of hypereosinophilia, even though to me it's kind of a neoplasm. It's just pre-neoplasm. Sometimes these patients may evolve to T-cell lymphoma, but a lot of times they don't. So nevertheless, I believe that this is something hematologist has to take care of. So this is idiopathic myeloid variant of hypereosinophilia. These are the people who have this flavor of myeloid neoplasm, myeloproliferative neoplasm. But we do not really have full diagnostic criteria to assign WHO label to this group. So 4 out of 9 of the following are required: dysplastic eosinophils, B12 elevation, tryptase elevation, anemia or thrombocytopenia, splenic enlargement, increased monocellularity, fibrosis in the marrow, increased number of loosely distributed CD25 positive spindle-shaped mast cells, and strong clinical suspicion for MPN. So obviously not, very clear cut, but, so I had few patients over years with this constellation of findings whom I could not diagnose with WHO-defined myeloid neoplasm and treated with imatinib, and they responded. So, there are limitations to our testing ability. We're getting better. This is the shrinking pool of patients, but nevertheless, they're still out there. The last patient whom I assigned this to was diagnosed just last year, and he's responding to imatinib. Young guy, 21 years old, goes to college. So this is WHO-defined myeloproliferative hypereosinophilic syndrome, can be related to any of these myeloid malignancies. And, so I treat all of them, but I would like to focus on the ones which are specifically known to cause high eosinophil count. And so this is chronic eosinophilic leukemia, as well as a group of conditions under the category, WHO category, myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. So there are a bunch of them. So starting from chronic eosinophilic leukemia, this is a very rare diagnosis. All of them are actually very infrequent. So even for hematologists practicing in this particular area, we don't see too many of those things. So chronic eosinophilic leukemia, you have to have hypereosinophilia as we defined it. Here they say for 4 weeks, not just for 2 weeks. And ICC, International Consensus Conference, which is competing with WHO for this classification, asks for 10% or higher, not just absolute eosinophil count more than 1.5. You have to find some clonal abnormality, either by cytogenetics or by mutation testing. And marrow should be abnormal, some kind of morphological abnormality, which is not quite fitting the diagnosis of other myeloid malignancies, but nevertheless not normal, or presence of increased blasts, either in blood or in marrow, but they have to be less than 20% because if they're 20%, it's acute leukemia. So also you have to exclude all other myeloid neoplasms associated with hypereosinophilia. So it's a very narrow diagnosis, very infrequent, but the outcomes of these patients is quite poor. So the survival is less than 2 years. So most of these patients have to be transplanted to be cured if they're able to go through the transplant. So the other big group, which was on the previous slide, is myeloid lymphoid neoplasm with eosinophilia and tyrosine kinase gene fusions. So the reason why I got interested in eosinophils is because I became the member of NCCN guidelines panel representing our cancer center on that panel. And I thought, if I'm on the panel, I should know more than average about this. And I started seeing patients, which motivated me to learn more, as well as presenting lectures, which is also helping to move your understanding on a different level. So there is this NCCN guidelines panel. It was actually, all of us were initially on MPN, and we still are on myeloproliferative neoplasm panel. And then this one appeared because we developed more ways of diagnosing these conditions, as well as specific treatments approved to manage these conditions. And it became necessary to guide others how to do this, because it is not a frequent situation, and you need to have some kind of guidelines to help you diagnose and manage this hematological malignancies. So the most common among them is PDGFR alpha rearranged MLNE. This condition is 80% of all of them. PDGFR beta is the next second, and both of them are actually very important to diagnose because their management is very different to others, and the prognosis is much better with treatment, which is basically imatinib, tyrosine kinase inhibitor imatinib, well known for its role in CML, chronic myeloid leukemia management. So this is my patient whom I saw a few years ago. He was working as a DJ. His wife is a photographer. They were traveling to destination weddings. We were in quite a few countries before he presented Dominican Republic, Dubai, Bali. I didn't think he was at increased risk of parasitic infection, though. So he presented with drenching night sweats, fatigue, bone pains for 1 month, and unintentional weight loss. In the last 6 months, he lost 18 pounds. So his primary care physician did the CBC, and he was found to have absolute eosinophil count of 6. He does have history of asthma, but I didn't think that asthma explains in his case this elevated eosinophil count because he had a lot of other things going on: B symptoms, night sweats, bone pain, unintentional weight loss. So his medications, he was only using albuterol as needed. He had unrevealing physical exam. The labs, in addition to high absolute eosinophil count, he had normal white cell count with normal ANC, but he did have normocytic anemia. Hemoglobin was 8.6, and platelet count was on the low side, 124, below normal. So the smear showed eosinophils with some hypergranulation, so there's a little bit of dysplasia there, microcytic anemia with some dacrocytes and nucleated red blood cells. When you start seeing this red blood cell abnormalities, this is an indication that something is happening in the marrow, usually fibrosis, but it can also be myelothesis when marrow is replaced by something. So he had elevated B12 and tryptase. That is a hint that something myeloid going on, myeloid neoplasm. And the rest of the workup was negative. That includes also tests for troponin and transthoracic echocardiogram. So you need to look at end organ damage when you're evaluating this patient with eosinophils, with eosinophil elevation, to understand how urgent it is to proceed with treatment. So he had negative PCR for BCR-ABL for CML, so CML was ruled out. And also he had negative JAK2 V617F mutation, which is the most common mutation in classical myeloproliferative neoplasms. So he did have a bone marrow, obviously, and so the marrow was very hypercellular, so it was almost no fat cells, more than 95% cellular. For a patient of his age, it should be 50-50, 50% fat cells, 50% cells, other cells. And so in his case, it was definitely hypercellular. You also can see the streaming. You can imagine that there may be fibrosis in this marrow. And obviously, it is very pink. So a lot of eosinophils in that marrow as well. And so the staining for fibrosis confirmed presence of reticulin fibrosis, the left upper picture. Also, trichrome stain revealed collagen fibrosis. This is a blue color on the right upper picture. And the staining for mast cells, CD117 staining and left bottom, basically shows you the scattered mast cells, which are not normal. They're spindle shaped. Usually they should be round, and they actually stained with CD25, which is abnormal stain. So far it is all consistent with myeloid neoplasm, but the diagnosis is not clear yet until we do genetic testing. And in this particular patient, the genetic testing which uncovered the diagnosis was the FISH test. So you can see that the FISH, there are 3 probes, the blue, green, and red. And this is chromosome 4. The probes, so in the cell, one chromosome has 3 probes, another one has 2. So the red probe is missing. That means CHIK2 was deleted. That's the gene in the middle. And it creates the situation when 2 genes, FIP1L1 and PDGFR alpha, move together. And as the result, there's a tyrosine kinase, PDGFR alpha, which is active. And that's what drives this disease. So this is actually cryptic on karyotyping when you just look at the chromosomes, because it's a small deletion. You will not be able to appreciate it when you look on the chromosomes under the microscope. So FISH is the way to diagnose this cryptic abnormality. So this is actually very good news because the treatment is very effective. So you can use 100 milligrams of imatinib, which is less than what we're using for CML, where the dose is 400. This is the approved by FDA indication for treatment. So basically what he has is PDGFR alpha rearranged MLNE, myeloid lymphoid neoplasm with eosinophilia. And, so the imatinib inhibits tyrosine kinase activity of this PDGFR alpha. So prednisone is given a lot of times concurrently during the first week to avoid myocardial damage, which may occur when you start the treatment. So this patient did very well. So a month later, he gained 4 pounds. His sweats and bone pain disappeared. Fatigue improved. Absolute eosinophil count normalized, and his anemia got better. Platelet count normalized. A few years down the road, he just relocated last year to Florida, where he's continuing to take imatinib, 100 milligrams with no problems. So I've mentioned PDGFR beta, another subtype of MLNE, which has great response to imatinib. All other ones are not so good, unfortunately. And I specifically want to highlight one of them, which is MLNE with FGFR1 rearrangement. The reason why I'm highlighting it is because we have specific FDA-approved treatment for this particular condition. The condition is associated with FGFR1 translocation. There are 16 known partners. The most common is on chromosome 13. Translocation 813 is the most common one. Usually not cryptic. You can detect it by karyotyping, but we also do FISH, which is just faster. And these patients may present in chronic phase, which is one of the myeloid malignancies, including myeloproliferative neoplasms, MDS or MDS-MPN. The median survival when you present with this disease in chronic phase is 9 months. The only way to cure them is allogeneic stem cell transplant. So blast phase is even worse. Patients usually present with one of the subtypes of acute leukemia. It can be myeloid, lymphoid, or mixed. And, survival for those patients is 30%, at 1 year. So, very, very deadly disease. So the breakthrough happened with this pemigatinib medication, which is the drug we have been using for management of patients with locally advanced to metastatic cholangiocarcinoma in the second-line setting. This is driven by FGFR2. The drug inhibits FGFR1, 2, and 3. And so when it was discovered that FGFR1 is driving this hematological condition, this drug was tried, and it looks like it has been active. So FDA approved it in August of 2022 based on the results of this FIGHT-203 study. So certainly not a very common condition. The approval happened with this phase 2 trial. 45 patients were enrolled. And the CR rate was pretty good, 74%. And it was much higher in chronic phase patients, 96%, as opposed to blast phase patients, 44%. So, and you can see that overall survival and progression-free survival curves are going down. So we know that this drug helps the patient, but doesn't cure the patient. So we still have to get them to transplant if we want to cure them. So this is the summary table for all the Milanese, and I actually highlighted the patients I have seen in my practice in the last 15 years. So I think there are like 6 of them. So I have 2 with PDGFR alpha rearrangement, 1 with PDGFR beta. I have no FGFR1 rearranged patients. I have 1 with JAK2 and 1 with ABL1. So the best results are for the first 2 groups with imatinib, and the other ones you can treat. Pemigatinib is approved for FGFR1 rearranged disease. But again, so ultimately, even though we have tyrosine kinase inhibitors, which may be effective, they are not giving these patients long-term outcomes we would desire. And that's why all of these patients beyond PDGFR alpha and beta rearranged, if we want to cure them, we need to get them to transplant sooner rather than later. So this is the list of treatments which can be considered for patients with hypereosinophilic syndromes. And imatinib is obviously a good treatment for PDGFR rearranged myeloid neoplasms, can be used as a second-line treatment for idiopathic myeloproliferative hypereosinophilic syndrome. So prednisone is actually first-line treatment for many patients because it takes time to figure out why they have hypereosinophilia. And if they have a syndrome, if they have ongoing symptoms, prednisone is the fastest way to control eosinophilia. And it may work for patients with primary and secondary eosinophilia, but not always. So some patients respond, and you're trying to get them off steroids, but you can't. And steroids long-term may be damaging in different ways. And so we have some steroid-sparing drugs, including hydroxyurea, pegylated interferon alpha-2A. I am familiar with these drugs, but I'm not so sure that other subspecialists are. And that may be one of the indications why these patients are followed by me. So some will be treated with methotrexate. These are patients who have rheumatological conditions. I have one patient with rheumatoid arthritis who presented with severe rash and very high eosinophil count, and initially was treated with steroids, but eventually was switched to weekly methotrexate and is doing well. I see her once a year, and her eosinophils are normal, so she's under the care of the rheumatologist. Cyclosporin once in a while may be helpful, and especially in patients with lymphocyte variant of hypereosinophilic syndrome. Finally, biologics. And nepolizumab was the first biologic drug approved for hypereosinophilic syndrome in 2020. So specifically for patients who had hypereosinophilic syndrome for 6 months without identifiable non-blood related causes. So that basically, these are patients, some of these patients had lymphocyte variant of hypereosinophilia. Others had idiopathic hypereosinophilic syndrome. So if we look at the group of FDA-approved anti-interleukin-5 therapies, so most of these therapies you're much more familiar with than I am. So all of these drugs are currently approved for asthma with eosinophilia, so severe eosinophilic asthma. Nepolizumab, in addition to being approved for hypereosinophilic syndrome, is approved for EGPA, and so is benralizumab, which is the drug against the receptor to interleukin-5. And obviously, targeting interleukin-5 in hypereosinophilia or hypereosinophilic syndromes makes sense because this is the cytokine which the eosinophils are dependent on to proliferate and multiply, not only multiply, but also survive longer. And, so one thing which I would like to bring up here, because I'm afraid I will forget until the conclusion slide, the interleukin-5 level is not really helpful. So, rheumatologists love to do the cytokine panel and look at interleukin-5, but it doesn't really predict who is going to respond to the treatment and what subtype of hypereosinophilic syndrome they have. So, something to keep in mind when you organize the workup for this patient or patients. So this is the mepolizumab study, which led to the approval in hypereosinophilic syndrome. It was a randomized double-blind study, 108 patients. They looked at hypereosinophil syndrome flares, the number of flares, as well as time to first flare on treatment with mepolizumab versus placebo. And there were less flares, and the time to the first flare was diminished. So it's kind of interesting way to do it, but I guess it is more important than the number of eosinophils, which we can control with these drugs. I think control of symptoms is the ultimate goal for this treatment. The adverse reactions were not so prevalent. Herpes zoster, URIs, and pain in extremities were described with this drug. So the next drug I'm going to talk about is benralizumab, and benralizumab is approved for asthma and AGPA, but is not approved for patients with hypereosinophilic syndrome. This was the study of 20 patients published in New England Journal of Medicine, so which by design was very interesting. So they actually blinded the clinicians to their eosinophil counts for the first 12 weeks. So patients were randomized to benralizumab versus placebo. And you can see on this graph that the initial, the primary endpoint was a drop of eosinophil count by 50%. And pretty much everyone accomplished this on benralizumab. And you can see there was diversity of things happening with placebo. 9 out of 10 patients accomplished reduction by 50% versus 3 out of 10 with placebo, significant difference. This informed the phase 3 study, Natron study, which was just presented at ASH 2025. So this was the study randomizing patients with hypereosinophilic syndrome to benralizumab 30 milligrams subcutaneously every 4 weeks versus placebo. And, so this was up to week 24, and then everyone was on benralizumab. So the primary endpoint is first hematologic relapse versus significantly, which was significantly delayed in patients who received benralizumab. You can also see on this graph how quickly the eosinophil count goes down. Both mepolizumab and benralizumab, they are very active, and the eosinophil count goes down within days. So the side effects, the tolerance was pretty good. I think the difference was just headaches for patients who have been receiving benralizumab. So biologic agents which are currently considered for hypereosinophilic syndrome include mepolizumab, which is FDA approved as an injection. Patient has to give themselves 3 injections every month. So basically monthly, but you have to use 300 milligram pens. So then there is benralizumab, which is now with the results of the Natron phase 3 trial, perhaps will be soon approved for this condition. We don't know yet. It is not yet approved. Dipemokimab is a long-acting antibody against interleukin-5, which is being studied in DESTINY study for hypereosinophilic syndrome patients. And this will be an easier way for our patients to give the drug because it's every 6 months. And dupilumab, is anti-interleukin-4 receptor antibody, and this one is studied together with anti-interleukin-5 biologics for patients who may have low eosinophil count but still have tissue damage, so to decrease the eotaxins, which are controlled by interleukin-4. So one thing to highlight before I go back to the patient is that mepolizumab and benralizumab do not work well for myeloproliferative hypereosinophilic syndromes. So the reason is that the production of eosinophils is not regulated by interleukin-5. Those are primary malignancies, and they're just producing eosinophils out of control without interleukin-5 involvement. That's why it is not surprising to see that, in both mepolizumab study and analysis and benralizumab analysis, these patients did not respond at all to the interleukin-5 directed therapies. So you can see that EGPA and overlap patients responded well. Again, numbers are small. Idiopathic hypereosinophilic syndrome is group of diseases where we don't know what causes it and suspect that some of them may have primary eosinophilia, and that's why not all of them respond to this treatment. So you can consider response to anti-interleukin-5 therapy as one of the diagnostic tests, right? So if your patient responded to it, it is likely that it is secondary rather than primary eosinophilia, because primary is not expected to respond to these treatments. So what happened to our patient? So she did have a workup, and so she had some findings with rheumatology workup. Her P anchor was indeterminate. She was PR3 positive, and ANA was positive. So ID workup was negative. She, by the way, did receive ivermectin because of her origins. She's from India before we started steroids. Lymphocytic variant hypereosinophilia workup was negative. That included what I discussed, T cell, receptor gene arrangement, and V beta by flow. And so she did have a normal IgE level. So her workup for primary hypereosinophilic syndrome showed mild elevation of tryptase and otherwise was negative. So the big question after this workup was done, what does she have, right? So this is WHOICC definition of idiopathic hypereosinophilic syndrome, which we think she may have, right? So she has sustained hypereosinophilia with the eosinophil count of more than 1.5. She has organ damage. So in addition to cholangitis, which has eosinophils, she also has heart damage, even though there are no eosinophils. But it is challenging to presume that she has another disease which causes myocardial necrosis when her absolute eosinophil count is 20,000. So we have to exclude reactive eosinophilia, lymphocyte variant hypereosinophilia, and other myeloid malignancies. We still have a question about exclusion of reactive eosinophilia in her case, because she does have findings concerning for inflammatory bowel disease and primary sclerosing cholangitis. She also has a little bit of rheumatological, abnormalities related to the testing which she had done. So hypereosinophilic syndrome with eosinophilic cholangitis, colitis, and endomyocarditis is one diagnosis. She may have IBD with primary sclerosing cholangitis and associated hypereosinophilic syndrome. And a typical EGPA per rheumatology still remains in the differential. So this is how she was managed. So this is ongoing, so I had to stop at some point. So, but basically when she presented at the end of December, her eosinophil count was as high as 20,000. She received prednisone. She's a tiny woman, so it was 40 milligrams, which for her is 1 milligram per kg. She got ivermectin, and then strongyloides testing was negative. So there was no response. There was concern about endomyocarditis. So she received high doses of methylprednisolone, which she responded to. And then she stayed on prednisone in between. But unfortunately, her eosinophil count would go up again. And she required this high doses of methylprednisolone on 3 occasions. So finally, we were able to get, on Saturday, we were able to get her benralizumab. And, so after she received a shot of benralizumab, her eosinophil count came down. And, since that time, since that administration, which happened on the 17th of January, her absolute eosinophil count remains normal. There was this one spike. Not sure how to explain it. It is possible that, so she's still on prednisone and we're weaning her off by about 5 milligrams every week, making sure that we decrease the dose when her absolute eosinophil count is not up. It should be less than 1. So we check the labs. If it is less than 1, we go down by 5 milligrams. She's on anticoagulation because of the left ventricular clot, which, by the way, she had been admitted a couple more times for recurrent cholangitis and now with pneumonia. But, TTE was done and clot actually resolved. So the response to benralizumab here points to secondary cause of this hypereosinophilia rather than primary myeloid disorder. So, and this is the summary of approach to patients who present to the hospital with absolute eosinophil count elevated, and here it's 1,500. Then we look at the symptoms. Again, symptoms may be anything. So we also have to evaluate organ function in a patient who presents with high eosinophils. That includes liver function tests, troponin, BNP, imaging studies, including scans, transthoracic echocardiogram, maybe even cardiac MRI, PFTs, and biopsies of the organs which we think may be damaged. So this workup helps us to answer the question about urgency of treatment. If we believe that symptoms and organ dysfunction are connected to high eosinophil count, we have to start treatment right away. So here's where PDGFR-associated neoplasm is important, because if you are able to turn around fish within 24 hours, which we do, we just have to order it, we know that this patient will be benefiting from imatinib, which works very quickly, so we can just start that. If PDGFR-associated neoplasm is not in the picture, the manifestations are concerning for EGPA, so high-dose steroids, including methylprednisolone at a high dose, and even cyclophosphamide may be used to control the damage to the lungs or to the myocardium. So patients who are not experiencing life-threatening symptoms we may wait to start treating them until comprehensive evaluation we discussed, step 1, step 2, is done, and then we can initiate treatment based on what we uncover. So there are some patients who do not have clinical manifestations who will require treatment. These are usually patients with myeloid neoplasms. These are my patients because if we don't treat them, their prognosis is very poor. Finally, there are patients who do not have any symptoms and they just have hypereosinophilia, and they may not need to be treated. Again, it's challenging to define this group, but you look at everything, and at the end, you have to decide, if a patient with the eosinophil count of 2,000 who have no other manifestations needs to be treated or not. So empiric ivermectin may be important for some of the patients with certain backgrounds before you start steroids to avoid dissemination of this infection with steroid use, and patients who are treated with imatinib for PDGFR-rearranged neoplasms should receive steroids to protect their heart. If you have concerns about heart involvement because of troponin or transthoracic echocardiogram. So this is the conclusion slide. Interleukin-5 is the cytokine to remember because we can target it, but levels are not helpful to manage patients. Workup includes 2 steps. First, you have to exclude secondary causes. I gave you the mnemonic of NAACP. And the secondary causes also include lymphocyte variant of hypereosinophilic syndrome, where you have to know what to order. And you can usually ask a hematologist to help you with that, but it is flow cytometry for aberrant T cells, as well as PCR and T cell receptor gene arrangement study for clonality. Second step is in the hematology court. So they usually do bone marrow biopsy, but even fish of blood can give you quick turnaround time if you suspect myeloproliferative hypereosinophilic syndrome. And, so if you find this CHIK2 gene deletion, imatinib is the answer. There are other fusions which are usually detected by karyotyping, and some of them still may be cryptic. That's why fish may be helpful in addition to karyotype. So clinical subtype actually predicts response to treatment. If you have PDGFR alpha-beta fusion or idiopathic myeloproliferative variant of hypereosinophilic syndrome, imatinib is the answer. For other patients, we have other tyrosine kinase inhibitors, which we can use, but allogeneic stem cell transplant is ultimately what they need. For the idiopathic hypereosinophilic syndrome, lymphocyte variant hypereosinophilia and GPA, use steroids, and then you can use interleukin-5 directed therapy, either mepolizumab and hopefully soon benralizumab when it is approved. So for patients who are on steroids, and they get stuck, so you're giving them 20 milligrams, you're trying to go down, and eosinophils go up, you may try to switch to hydroxyurea interferon. I usually keep them going until they're 10 milligrams, and if they are okay on 10 milligrams or less, eosinophils don't come up, they don't have manifestations of their hypereosinophilic syndrome, they remain on this prednisone. If I have to use higher doses, that's where I would consider anti-interleukin-5 therapy. Finally, these are patients with complex clinical manifestations, and etiologies of their elevated eosinophil count. Multidisciplinary approach is certainly important for comprehensive care. Thank you.
Thanks very much for your wonderful presentation and excellent renewal of our knowledge about this very complicated area, which is very fast moving. Does anybody have any questions?
Thank you, Nikolai. That was really, really nice. So I guess one of the questions that sometimes we have is when we're dealing with eosinophilia, not hypereosinophilic, but kind of like relatively high, particularly in patients that have been in areas where parasites are endemic, right? The question that, like in my case, for example, we treat patients with, asthma. There's a lot of overlap with significant eosinophilia. The question is, like in this patient, for instance, like when do we go for antiparasitic treatment before considering a biologic, knowing that it could potentially exacerbate like systemic parasitosis, right?
So if you have, so you have to ask for, the origins of the patient, right? So if it is, this patient is from India, so Central America, so are, the area which is, known for high prevalence of these infections. And, so you can just use ivermectin when you consider acute treatment. And obviously you can do the testing. Stool fova and parasites, one dermatologist told me you have to do it 3 times because it's, you can still miss the parasite. So if it is beyond strongyloides testing, serological testing, and stool fova parasite, I'll send them to ID.
I have a question that's kind of related to this.
Mm-hmm.
How long do you actually expect the eosinophilias to last after you've treated parasitic infection? And is there a point in which you start to worry that it's not because of that?
So, it's a challenging question for me because I am not, in this infection disease clinic where these patients are seen. So the biggest expert in the whole world, I think, well, at least in the United States, is Amy Cleon. She is in charge of eosinophilia unit at NIH, and she's not a hematologist. She is actually a parasitologist. So I think she would be able to answer this better than I do. But, so I think it should be relatively short-lived, but, I would give it a month at least, and I do not really see them more frequently anyway. So I think if you treated them and you treated them appropriately and eosinophilia doesn't go away, it's probably not related to parasitic infection, especially if you treated them empirically without evidence of parasitic infection.
I have a question, Nikolai, is perhaps I missed it, but is there any known particular driver of the lymphocyte hypereosinophilic variant? Any causative triggers that we know of for that?
So, there are 2 types of cytokines. So, I'll go back to the beginning. So I think, and, this is evolving field as well, but the interleukin-5 is obviously the main culprit, which we're targeting. We're targeting for that specific reason. So, but, you have, so the highest eosinophil count I saw in a patient was 107. And this patient had very refractory multiple myeloma. So we knew that the eosinophilia is secondary. We could not find what drives it. Even though I told you I'm not checking interleukin-5, I checked, it was normal. So certainly, I do not really have ability to check a lot of other things like GM-CSF and interleukin-3 and so on and so forth. But interleukin-5 is the leader from the standpoint of causing the differentiation of eosinophils, increasing their number, promoting their survival. There are some other cytokines I suspect my myeloma patient had, so maybe GM-CSF, challenging to say. And so there are also other cytokines which are involved. And, so these are the cytokines which attract eosinophils to tissues. And this is, if there's inflammation going on, you have high eosinophils, and they're also attracted to tissue by interleukin-4, interleukin-13. Dupilumab, interleukin-4 receptor antibody, which, receptor for both interleukin-4 and interleukin-13, is very helpful. And that's why, so sometimes combination of these 2 drugs is very reasonable, and that's what is being studied. So I think these are the group of cytokines which we have to pay attention to in secondary eosinophilia.
I guess one sort of related question is what drives the clonality or the initiation of that clonality?
So,
especially amongst those people who don't go on to develop the acidic.
So you're asking a very fundamental question, right? So what's the origin of cancer, right? So lymphocytic, so it's not lymphocytic, it's lymphocyte variant of hypereosinophilia is the official name for this. I think one of the reasons why we cannot define it is because this type of lymphocyte is very difficult to find. And, sometimes we just have very high Ig level, but we still don't have flow cytometry to show abnormal cells, neither in the marrow nor in blood. We don't have T cell receptor gene arrangement studies or other tests. And we still believe that, ruling out everything else, that maybe that's what we're dealing with, just based on this hint. So where are the cells? Why are they there? I don't think we know. It's like, so, they are not normal. They are probably clonal, but we cannot, well, they are clonal because we see that. So I think studying them genetically is a little bit more challenging. And, I have not seen those types of studies. But we know that some of these cells, similar to what happens with clonal hematopoiesis of internal potential when people develop myeloid neoplasms, some of these patients with this lymphocyte variant hypereosinophilia develop T-cell lymphomas. Not all of them, right? And there's a big latency. So that's why I follow them like once a year. And, so I tell them, if something happens to you, call us, because we may need to do imaging to see what's going on. And one of the patients recently evaluated by our hematology consult team, she was destined to come to my clinic. So she had multiple biopsies. She had some lymphadenopathy, spleen enlargement. So we thought that she has lymphocytic variant of hypereosinophilia because she had T-cell gene rearrangement. And, so before she arrived to my clinic, like a week prior, so the biopsy of one of the lymph nodes came back that it is T-cell lymphoma. So, we have to rule this out, right? So because it's a premalignant condition, but sometimes patients who have lymphadenopathy and who have splenomegaly may already have lymphoma.
There's one final question from the chat from Dr. Mathey. He would like to know, when should pulmonologists refer patients with eosinophilia to you? Key question.
So, should it be me or a classical hematologist? Because I'm a malignant hematologist. So I'm certainly interested in a subset of these patients, right? So lymphocyte variant of hypereosinophilia, myeloproliferative variant of hypereosinophilia. This is, what I am dealing with. So so I see this referrals comes through, and I have to look through them to decide if I'm going to see them or someone else. And I'm looking at different hints to figure that one out. So I can send some to classical hematology where I truly believe it is secondary. And ultimately, so if something doesn't fit to your patient who has asthma, right? So hypereosinophilia, other organ damage. So I think these are the patients who you may want to look at from the standpoint of hematological disease, because damage to the lungs may be just part of hypereosinophilic syndrome and not primary asthma. And who is this patient? Again, so I hope this lecture helps you to understand how we think. And so you will be thinking the same way. If it doesn't fit in your typical asthma presentation, then, so we're happy to see this patient, to look for other reasons for this patient beyond allergies, to have hypereosinophilic syndrome. And a lot of times we'll just bring them in, we do all the workup, and we send them back to you. So, but, we have done what we could, right? Some of them will have idiopathic hypereosinophilic syndrome with lung damage, and then we can share those patients. The treatment is the same: steroids, mepolizumab, maybe benralizumab.
No other questions. Thank you so much.
Thank you.
Dr. Podoltsev.